Imagine this. You're in the middle of a perfectly ordinary day. Maybe you're walking the dog or just sitting at your desk when suddenly it hits. A strange, undeniable sensation in your chest. Your mind races. Is it just that spicy lunch? A pulled muscle from yesterday's workout? Or, in the pit of your stomach, the chilling thought, is this something far more serious? That moment of uncertainty, the quickening of your pulse, the fear of the unknown, it's a feeling many of us know or dread ever knowing. Chest pain is, without a doubt, one of the most common and often most frightening reasons people rush to get medical help. It's a symptom that demands immediate attention, but its causes are incredibly diverse, from the utterly mundane to the genuinely life-threatening. The real question is, how do you, or even an experienced doctor, begin to unravel that complex and often terrifying mystery?
It's a profound diagnostic challenge, isn't it? Really is. The human body has a surprisingly limited vocabulary for distress, you know. And so many different conditions, both benign and critically dangerous, can manifest as that singular, alarming symptom we call chest pain. Our mission in this deep dive is to, well, equip you with the knowledge to cut through that ambiguity, to understand the nuances, to recognize the subtle telltale signs, and to grasp the critical questions that medical professionals use to navigate this complex landscape. We're going far beyond the surface today, aiming to give you a clearer, more informed picture of what might truly be happening when your chest sends out an alarm.
Exactly. We're not just going to list symptoms. We're going to dive into the language your body speaks and, crucially, how to interpret those vital signals. We'll explore the subtle distinctions between different types of pain, illuminate the critical red flags you absolutely need to know, and reveal the cutting-edge diagnostic tools that truly help save lives. It's about empowering you to be a more informed advocate for your own health. But before we truly plunge into the heart of this discussion, we want to take a moment to give a special thank you to London Heartbeat Z Academy UK. They've provided invaluable educational support in making deep dives like this possible. They are a fantastic, truly comprehensive resource, offering over 150 popular courses designed to broaden your knowledge across a wide range of subjects. We wholeheartedly encourage you to explore their extensive offerings and connect with them. You can subscribe to their social media channels, Facebook, Instagram, and YouTube for regular, absolutely free updates that will keep you informed and engaged with the latest insights. And for those of you who want to dive even deeper to truly accelerate your learning, consider their higher-level YouTube membership. This offers incredible perks like early access to educational videos and even personal chats and guidance sessions directly with their experts. They are all about empowering you with knowledge, just like we aim to do right here.
Our goal today is clear: to demystify chest pain. By the end of this deep dive, you'll have a much richer understanding of everything from the classic signs of angina to those less obvious, often dangerous atypical symptoms. We'll explore how different populations might experience pain differently, and we'll uncover the sophisticated diagnostic tests used to pinpoint the cause. You'll walk away more informed, more confident, and better equipped to be proactive about your own health and perhaps even the health of those around you.
So let's unpack this. Let's kick things off with a story to truly bring this to life, a scenario that is, well, incredibly common. Imagine Sarah, a seemingly healthy, active 45-year-old. For a while now, she's been noticing a mild, rather dull ache in her chest, usually after she climbs those 3 flights of stairs to her office at work. The good news is it always seems to go away when she sits down and rests for a minute. She's dismissed it, telling herself she's probably just a bit out of shape or maybe stressed. But then one day, the ache is different. It's more intense, feels less like an ache and more like a tight constricting band squeezing her chest. And she also feels a strange, clammy sweatiness. Now her heart is really pounding.
Sarah's evolving situation perfectly encapsulates the immediate dilemma faced by patients and doctors alike, doesn't it? Is this simply her being a bit winded from the stairs, as she initially thought? Or is her body now sending a much more urgent and potentially dangerous message? The critical insight here is that understanding the nature of that discomfort, its quality, what precisely triggers it, and what consistently relieves it is the absolutely crucial first step. It's how we begin to differentiate between a benign, self-limiting issue and something that could be life-threatening. Sarah's story will help us explore the precise criteria we're about to discuss, as it perfectly illustrates the challenge of interpreting those early, often subtle signs. It's not merely about the presence of pain, you see, but the intricate context in which it appears and disappears, and how that context might be shifting.
Okay. So the immediate takeaway from Sarah's first experience, even with that mild ache, is that seemingly minor chest discomfort, especially when linked to exertion and then relief by rest, warrants careful consideration. It's not always just being out of shape.
Right.
The pattern is often more telling than the pain's initial intensity. Now, diving deeper, chest pain is famously a tricky symptom because so many different things can cause it. It's almost like the body has this one big, alarming check engine light, but it could mean anything from low wiper fluid to a failing transmission. It's not always about the heart, even though, let's be honest, that's usually our biggest and most immediate fear.
That's a perfect analogy, yeah. The initial evaluation of chest pain absolutely has to cast a wide net. We have to consider everything. On one end of the spectrum, you have serious cardiac events like a heart attack or an unstable angina episode. But on the other, equally common, are non-cardiac causes. Musculoskeletal issues, perhaps a strained muscle from lifting something heavy or even just coughing intensely. Digestive problems like acid reflux or esophageal spasm, which can mimic heart pain almost perfectly. And as many of us unfortunately know, even psychological factors like anxiety or panic attacks can cause alarming chest discomfort. The core challenge for medical professionals and for you, the informed listener, is quickly and accurately narrowing down those possibilities. We need a systematic way to approach this inherent ambiguity to truly understand the signal amidst all the noise. To make sense of this overwhelming range of possibilities, doctors have developed a way to categorize chest pain into a few broad buckets. What are these main distinctions that help them begin to unravel this complex puzzle, almost like the first crucial sorting step? We essentially group them into what we call anginal pain, which itself has further classifications of typical and atypical presentations, and then non-anginal pain, which very often encompasses non-cardiac causes. This classification isn't just an academic exercise, it's a deeply practical framework that guides us in how to triage patients and direct further investigations. Think of it as the first, most fundamental filter in a complex diagnostic process. It allows us to quickly assess the immediate likelihood of a heart-related problem that stems from blocked coronary arteries versus something else entirely. It's about organizing the vast amount of information we get from a patient's description to make informed and often rapid decisions.
All right, let's get specific, because clarity here is vital. When we talk about typical angina, what exactly are the key defining features that medical professionals look for? What makes it typical? The textbook example, so to speak.
Okay. For chest discomfort to be considered typical, or as we sometimes say, definite angina, it absolutely must meet three very specific and important criteria. Missing even one of these significantly changes the diagnostic probability. First, and this is crucial, it must be a substernal chest discomfort with a characteristic quality and duration. This means the pain is felt behind the breastbone, centrally in the chest, not off to the side. And it's typically described with words like a heavy pressure, a squeezing sensation, a tightness, or even a feeling of strangling or a heavy weight. It's rarely a sharp, fleeting pinpoint pain. Second, and this is perhaps the most defining characteristic, it's provoked by exertion or emotional stress. This is a direct consequence of the heart's physiology. The pain appears when the heart's demand for blood and oxygen increases. During physical activity like walking up a hill, running for a bus, or even in moments of intense emotional distress. It's a direct signal that the heart muscle isn't getting enough oxygen to meet that increased demand. And third, it's consistently relieved by rest or by taking nitroglycerin. When the demand on the heart lessens by simply stopping the activity, or when nitroglycerin, which is a medication that dilates blood vessels, including the coronary arteries, is taken, the pain subsides relatively quickly, usually within minutes. If you experience all three of these criteria consistently, it's highly indicative of typical angina, strongly pointing towards an underlying issue with the coronary arteries, often a narrowing that limits blood flow.
That makes so much sense. It's like the heart saying, I'm working too hard and I'm not getting enough oxygen to keep up with what you're asking of me. It's a direct, almost physiological complaint. But as you mentioned earlier, symptoms aren't always so clear-cut. What if someone only experiences some of those criteria? That's where atypical angina comes in, right? It seems like that would be a very common presentation given how varied people's symptoms can be in real life.
Precisely. You've hit on a very common clinical scenario, and it's why we need these nuanced classifications. If a patient meets only two of those three criteria we just discussed for typical angina, we classify it as atypical angina, or as you correctly inferred, probable angina. This classification is a critical flag. It means the likelihood of it being a heart-related issue is still significant enough to warrant serious attention and further investigation. But it's not as definitively clear-cut as a typical presentation. It tells us that while it might not be the textbook case, we certainly can't and shouldn't rule out angina without more thorough checks. It's like having 2 out of 3 key pieces of a puzzle. It's part of the bigger picture, but you don't have the full clarity yet to make a final call. It demands further exploration.
And what if someone only hits one of those criteria, or even none at all? Does that immediately mean they're in the clear and it's definitely not their heart?
That's an excellent follow-up question, and it's important to clarify. If a patient only meets one or none of those 3 criteria, we then lean towards classifying it as non-cardiac chest pain. This is a crucial distinction to make for guiding the diagnostic process, but it certainly doesn't mean the pain is not serious or doesn't require attention. What it does mean is that, based on the initial characteristics of the pain described by the patient, it's less likely to be directly originating from the heart's blood supply due to coronary artery disease. The immediate focus of investigation then often shifts away from the most urgent concern of an acute heart attack or severe angina. Instead, we might start thinking about conditions like gastroesophageal reflux disease, or GERD, which can cause severe burning chest pain that mimics heart pain very closely. Or it could be muscle strain from physical activity, which can be quite painful but less dangerous. Even anxiety and panic attacks are well known to cause significant chest discomfort, sometimes described as sharp or pressure-like. The key, however, is always to systematically and swiftly rule out the truly life-threatening cardiac causes, first due to their urgency and potential for severe, irreversible outcomes. Only once those are confidently excluded do we broaden our search for other, often less immediately dangerous explanations. The diagnostic journey is about methodical elimination, prioritizing the most critical threats.
Okay, so beyond those core 3 criteria of location, provocation, and relief, how do we describe the pain itself? Is there a specific, almost clinical vocabulary that helps doctors differentiate between cardiac and non-cardiac pain? Because the words people use seem so subjective.
Absolutely, and you've hit on a critical point about the subjectivity of pain. That's precisely why we've developed very specific terms. The character of the pain is incredibly informative and offers some of the most distinguishing clues. Cardiac pain, particularly angina, is often described with very specific terms that convey a sense of weight or constriction. Patients might say it's compressing, feeling like a heavy weight or elephant sitting on their chest, or constricting like a tight band or vice around their chest. Other common descriptors include squeezing, strangling, a dull ache, or burning, which can sometimes be confused with reflux. It's generally a heavy, oppressive, or aching sensation rather than a sharp, stabbing one. Crucially, it's a discomfort that's hard to pinpoint with one finger. It tends to be more diffuse, often covering a broader area.
And for non-cardiac pain, is there a different set of words that usually come up, painting a different picture?
Yes, quite distinctly. Non-cardiac chest pain is often described with very different characteristics. People might say it feels pricking, like tiny needles, or lightning-like, a sudden, sharp electric jolt. Another common description is catching, where a sharp pain occurs with specific movements, a deep breath, or even a cough. These sharp, often localized, or fleeting pains are much less typical of a heart issue. This distinction in the descriptive language used by the patient helps to guide our initial thoughts and differential diagnoses significantly. It's why listening carefully, not just that a patient has pain, but how they describe their pain is absolutely paramount in the initial assessment. It's not just semantics, it's diagnostic gold.
Does where you feel the pain, and especially if it spreads or radiates, matter a lot? Is it always just in the chest, or can it show up in other, sometimes surprising places?
Immensely, yes. The precise location and any radiation of the pain are critical pieces of this diagnostic puzzle. As we've discussed, classic cardiac pain is typically substernal, meaning it's located directly behind the breastbone. However, it's very important to understand that it often radiates. This radiation is a hallmark feature, and it tells us a lot about the nerve pathways involved. Common patterns include spreading to the left arm, which is perhaps the most famous and widely recognized, but it can also radiate to the left shoulder, the jaw, the neck, the back, or even the epigastric area, that upper abdominal region just below the breastbone. Understanding these typical pathways helps us differentiate cardiac pain from other types. The pain isn't always confined to a small pinpointed spot that you can indicate with one finger. It often spreads because the heart's sensory nerves are connected to a broader network. Specifically, the sensory nerve fibers from the heart primarily travel through the T1 to T5 segments of the spinal cord, though the referred pain can extend from C3 up in the neck down to T10 in the mid-back, which explains the surprisingly diverse radiation pattern. It's essentially a phenomenon of referred pain, where the brain interprets signals from the heart as coming from other parts of the body that share the same nerve pathways.
What about other symptoms that come along with chest pain? Sometimes it's not just the pain, but the whole body seems to be reacting, almost like a separate set of alarm bells going off simultaneously.
You're absolutely right. These associated phenomena are incredibly critical clues, often indicating the body's systemic response to the intense stress of an underlying condition, especially a serious cardiac one. We look for signs of either sympathetic or parasympathetic nervous system overactivity, as they each paint a different picture of the body's distress. When we see sympathetic excess, you should immediately think of the fight or flight response. This means the body is under acute stress and is mobilizing all its resources. Symptoms include profuse sweating, a general feeling of weakness, intense anxiety, sometimes even a terrifying sense of fear or impending doom. Palpitations, often described as a rapid heart rate or tachycardia, and hypertension, which is elevated blood pressure. These are all the body's primal ways of trying to cope with an acute, perceived threat to survival. On the other hand, parasympathetic excess is more of a rest and digest system gone awry response, often seen in more severe or prolonged events or with certain types of heart attacks, particularly those affecting the inferior part of the heart. Symptoms here include nausea, sometimes leading to vomiting, bradycardia, a slow heart rate, and hypotension, low blood pressure. The presence and combination of these associated symptoms can be incredibly telling and often prompt immediate aggressive medical intervention as they signal a profound physiological disturbance.
Okay, so if we look at the exact location, the specific character of the pain, where it radiates to, and these associated symptoms, whether it's sympathetic or parasympathetic excess, can we start to get a pretty good sense of how likely it is to be angina? Is there a sort of mental scoring system for this?
Yes, there absolutely is a clinical framework for this. It's not a rigid mathematical score that we calculate with a formula, but more of a rapid, intuitive clinical judgment based on how many of these key characteristics are present. We mentally assess this angina likelihood score very quickly. If all four are present, that is, the classic substernal location, a typical compressing or squeezing character, radiation to areas like the arm or jaw, and associated sympathetic or parasympathetic symptoms, then it's highly likely to be angina. The probability is very high, and we escalate our concerns immediately. If 2 to 3 of these characteristics are present, it's still considered likely to be angina, and definitely warrants thorough investigation, but perhaps not with the same absolute certainty. However, if only one or none of these are present, angina is considered unlikely. This rapid clinical assessment helps us quickly triage patients and decide on the urgency and appropriate direction of further diagnostic steps. It's about building a comprehensive picture from all available symptomatic information to guide our next move.
And what makes the pain better or worse? That seems like a really important question for a doctor to ask, almost like finding the specific triggers and the unique antidotes for a patient's pain.
It is absolutely fundamental, perhaps one of the most revealing questions we can ask. Understanding what consistently triggers the pain, what makes it start or worsen, and what reliably alleviates it, what makes it go away, provides immense insight into the underlying mechanism. For instance, if the pain is consistently triggered by physical exertion, like walking uphill, carrying heavy groceries, shoveling snow, or even by cold weather or intense emotional stress, these are all factors that dramatically increase the heart's workload and its demand for oxygen. If the heart has narrowed arteries, it simply can't meet that increased demand. Similarly, the pain is consistently relieved by simple rest, by stopping the activity that provoked it, or by specific medications like nitroglycerin, which is a powerful vasodilator that widens the coronary arteries. That's a strong, almost classic indicator of anginal pain. These factors are often the direct link to changes in myocardial oxygen demand or supply, telling us whether the heart is getting enough blood flow when it needs it most. This information is invaluable, not just for diagnosis, but also for guiding personalized treatment strategies. It helps us understand the dynamic interplay between activity, rest, and the heart's ability to cope.
We often hear about those classic textbook symptoms, but the human body, as you've pointed out, likes to throw curveballs. It rarely follows the script perfectly. Who are some of the groups that might present with atypical chest pain, making diagnosis even more challenging and potentially delaying critical care?
This is a critically important point, because overlooking atypical presentations can, unfortunately, lead to delayed diagnosis and potentially poorer outcomes. Several groups are particularly prone to experiencing atypical presentations of angina, or even a full-blown heart attack, often without the classic crushing chest pain. First, and perhaps most prominently, are individuals with long-standing diabetes mellitus. Due to a condition called diabetic autonomic neuropathy, which is nerve damage affecting the involuntary nervous system, diabetics may not feel the classic pain signals. Their pain pathways are blunted or altered, so they might experience a heart attack with no chest pain at all, or only very vague discomfort like shortness of breath, fatigue, or nausea. Similarly, elderly individuals, especially those with broader autonomic dysfunction, can also have significantly altered pain perception. Their nervous system might not transmit pain in the typical robust way we expect. What might be excruciating pain for a younger person could be a mild ache or just a feeling of being unwell for an older individual. Patients who are already on beta blockers and other anti-anginal medications can also have atypical symptoms. These medications are specifically designed to reduce the heart's workload and oxygen demand. While this is beneficial for managing heart disease, it means they can alter the body's natural response to ischemia, potentially masking or changing the character of anginal pain. The medication itself is doing part of the work, so the body's distress signal might be muted. And finally, a very specific group: post-TPAG, coronary artery bypass graft patients. After bypass surgery, certain areas of their heart may have undergone denervation, meaning the nerve pathways responsible for pain sensation have been disrupted. This can lead to altered sensations or even no pain at all during an ischemic event, making diagnosis much trickier for them than for someone who hasn't had that surgery.
So the crucial takeaway here is that you absolutely cannot just rely on someone saying, I have crushing chest pain to suspect a heart issue. Sometimes it's far more subtle, like unexplained shortness of breath, overwhelming fatigue, or just a feeling of being generally unwell, even when it's something incredibly serious. That really underscores the need for a high index of suspicion in these populations to look beyond the textbook presentation.
Absolutely. The absence of classic chest pain never rules out a cardiac event in these vulnerable groups. We have to be hypovigilant and look for those other, less obvious clues. Now, pivoting slightly, can the location of the pain sometimes give a hint about which specific coronary artery might be involved, even down to a particular branch? Are there localized patterns? Sometimes, yes, there are some patterns, though it's important to stress that these are clinical observations and useful associations, not definitive diagnostic rules. They provide clues, not absolute certainties, and are always interpreted in the broader clinical context. For example, pain that primarily manifests in the epigastric area, that upper abdominal region, or radiates significantly to the jaw or neck, has been empirically associated with blockages in the right coronary artery, RCA, in approximately 90% of observed cases. The RCA supplies blood to the bottom wall of the heart and often the right ventricle. While not a definitive diagnostic, it's a useful clinical observation that can guide initial thoughts about the potential vessel involved, especially when considering initial treatment strategies or anticipating potential complications. The left anterior descending LAD artery, often dramatically called the widowmaker, due to the severity of blockages there and its impact on a large area of the heart, typically causes more classic severe substernal chest pain, often with extensive radiation and more pronounced symptoms. These associations, while not perfect, help to focus our diagnostic process. It's also vital when we're thinking about these nuanced presentations to acknowledge that there can often be a clinical versus physiological discrepancy. What we observe clinically in terms of a patient's reported symptoms might not perfectly align with the underlying physiological reality of their heart. For instance, someone might have significant coronary artery blockages, even severe ones, and still report minimal or no symptoms at all. This is especially true if they lead a very sedentary lifestyle, where their heart never reaches a high demand, or if they are in one of those atypical populations we just discussed, like diabetics. Conversely, someone might report very dramatic and concerning symptoms, describing intense pain, but their diagnostic tests, including angiograms, show no significant blockages. This discrepancy reminds us that the human body is incredibly complex, and symptoms are just one part of the overall clinical picture, always needing to be integrated with objective findings and a deep understanding of individual patient factors.
That's a truly fascinating concept. The body's internal state not always matching its outward expression. It adds yet another layer of complexity. What are some of these special types of angina that don't always fit the typical exertion-related pattern we discussed earlier? It sounds like angina truly has many different faces, and they're not all about running on a treadmill.
Indeed, it does, and recognizing these variations is key because they highlight the complexity of diagnosing and managing coronary artery disease. They don't always follow the classic script of pain with activity. First, there's rest angina. As the name suggests, this occurs without any physical exertion, often when the patient is completely sedentary, frequently in the early morning hours. Its mechanism is usually related to an increase in coronary artery tone or vasospasm, where the arteries themselves suddenly narrow, reducing blood flow even when the heart is at rest. It's not about increased demand, but rather a profound reduction in supply. Closely related is nocturnal angina. This is similar to rest angina, but specifically occurs at night, often so severe that it wakes the patient from sleep. This can be related to our natural circadian rhythms, our body clocks which influence blood pressure and hormone levels, or even changes in body position during sleep that might affect cardiac preload or blood flow dynamics. Then we have postprandial angina, which is angina that occurs specifically after a meal. This is thought to be due to the body redirecting a significant amount of blood flow to the digestive system to aid in the intense process of digestion. In someone with compromised or narrowed coronary arteries, this redirection of blood can reduce the supply available to an already struggling heart, leading to ischemic pain. The gut essentially steals blood from the heart when the heart needs it. A rather unique and sometimes perplexing phenomenon is the second wind phenomenon. Initially, a patient experiences angina during exertion, perhaps while walking. But if they push through that initial pain or pause briefly and then resume, the pain actually subsides, and they can continue their activity, sometimes for a considerable duration. This is often attributed to the recruitment of collateral circulation, essentially, the body developing alternate, smaller blood supply routes to bypass blockages, or the release of endogenous vasodilators, which are natural substances in the body that widen blood vessels, helping to restore blood flow to the ischemic area. It's the heart's own ingenious workaround. And finally, variable threshold angina. This is angina that occurs at different levels of exertion on different days, depending on a host of other factors. One day, a patient might walk 5 blocks without pain, but the next day, due to emotional stress, exposure to cold weather, or even just a different time of day, they might experience angina after only 2 blocks. It highlights how incredibly sensitive the heart's oxygen supply-demand balance can be to external environmental and internal physiological influences, making it a frustratingly unpredictable experience for the patient.
Let's revisit Sarah from our first example, because her story is taking a turn that perfectly illustrates a critical concept. Her mild ache after stairs, which she initially dismissed, has now become more frequent. Crucially, it's now sometimes even occurring at rest, completely out of the blue. The feeling of tightness lasts longer than before and isn't as easily relieved by simply sitting down. This sounds like her situation is getting much, much more serious.
Sarah's evolving symptoms are indeed a classic and concerning example of how a relatively stable condition can transform into something far more urgent and dangerous. This progression from what might have been chronic stable angina to unstable angina, or even an impending heart attack, is exactly what we need to differentiate quickly and accurately. It highlights the dynamic nature of heart conditions and why recognizing the characteristics of unstable is so vitally important. What Sarah is experiencing now demands immediate medical attention because her risk has significantly increased. The message from her body has shifted from a gentle warning to an urgent alarm.
That's a powerful point. The practical application here is critical.
Okay.
A change in the pattern, frequency, duration, or intensity of chest pain, especially if it starts occurring at rest or with less exertion than before, is a critical warning sign that requires immediate medical attention. So in the broader sense, we have these 2 overarching categories: chronic coronary syndrome, or CCS, and acute coronary syndrome, or ACS. What's the key difference between these two, and why is that distinction so crucial for patient care and for us to understand?
The distinction between CCS and ACS lies profoundly in the urgency and, more importantly, in the underlying pathophysiology, the biological mechanisms at play within the coronary arteries. Chronic coronary syndrome, CCS, implies stable, predictable angina. This is often the case with chronic stable angina, where the pain occurs reliably with a certain consistent level of exertion and is relieved predictably by rest or specific medications. It's a chronic condition managed over time, with a relatively predictable course. Acute coronary syndrome, ACS, on the other hand, represents a sudden, critical reduction in blood flow to the heart, typically due to a plaque rupture and clot formation in the coronary artery. This is an acute, often life-threatening event requiring immediate intervention, as it can lead directly to a heart attack. The questions we ask clinicians often revolve around this precise distinction, trying to identify any shift toward instability. Has the frequency of the pain become more common, occurring more often? Does its duration last longer than it used to? Has the threshold of walking or exertion before the angina occurs significantly decreased? Can you walk less distance or do less activity now before the pain starts? And crucially, has there been any recent increase in severity, frequency, or occurrence in the last month?
So an increase in any of these characteristics, more frequent pain, longer lasting pain, pain with less effort, indicates that things are actively getting worse, potentially moving from a chronic, manageable state to an acute, dangerous one.
Precisely. Any increase in the frequency, duration, or intensity of the pain, or a lowering of the threshold at which it occurs, is a significant red flag. It's a strong indicator that the underlying coronary artery disease is worsening, and the patient is at a much higher risk of an imminent heart attack or other severe cardiac event. This warrants immediate and aggressive diagnostic and therapeutic intervention because time is muscle, and every minute counts in preventing irreversible heart damage.
Let's really focus on unstable angina as it sits right on that dangerous cusp. What exactly makes it unstable and so concerning that it's almost treated as an emergency, even if it's not a full-blown heart attack yet?
Unstable angina is indeed a critically important classification, often seen as a pre-infarction state. It's considered a heterogeneous subset of syndromes, meaning it can manifest in different ways and has varying underlying causes, often involving plaque rupture and partial thrombus formation. But it shares a critical characteristic: the absence of clear ECG changes or enzymatic evidence of an acute myocardial infarction, heart attack. This means that while the heart muscle cells aren't yet dying, as indicated by blood tests like troponin, the heart is under severe acute stress due to a sudden, significant reduction in blood flow. It's a very high-risk situation. It's often referred to by other names that emphasize its severe nature, such as pre-infarction angina, because it so frequently precedes a heart attack. Crescendo angina, due to its escalating nature, acute coronary insufficiency, or intermediate coronary syndrome. We specifically define it by one of three distinct scenarios. First, crescendo angina. This is the most common presentation and refers to a worsening pattern of angina in a patient who previously had chronic stable angina.
The pain becomes more severe, lasts longer, or occurs more frequently than it used to, and might be triggered by less exertion. It's an unmistakable escalation of previously known symptoms. Second, angina at rest or minimal exertion. This is a new development for the patient, where chest pain begins to occur even when they're not physically active or with very little effort. This is a highly concerning sign, indicating a significant impairment of blood flow even without the added stress of physical activity. And third, angina of new onset, 1 month. This refers to chest pain that has just started recently, within the last month, and is already severe, frequent, or prolonged. It's a sudden, concerning presentation in someone who previously had no such symptoms, suggesting a new and aggressive progression of underlying coronary artery disease.
So it's not a heart attack yet, but it's a very loud, very clear, very critical warning sign that a full-blown heart attack could be imminent. And it demands the same immediate, urgent attention and intervention as a heart attack.
Exactly. It's a critical state that requires immediate intervention to prevent irreversible heart damage and to stabilize the patient. Treating unstable angina aggressively is absolutely key to preventing its progression to a full-blown myocardial infarction. It's our window of opportunity to intervene before permanent damage occurs.
This is truly interesting. Does when an acute coronary syndrome happens matter? Like, is there a particular time of day it's more common, or is it pretty random throughout the 24 hours?
Yes, there's a fascinating and very well-documented phenomenon known as circadian periodicity for acute coronary syndromes. They often show a significantly higher incidence in the morning hours, typically shortly after waking. This isn't random. It's intricately linked to several profound physiological changes that occur with the awakening process, essentially making the cardiovascular system more vulnerable during this specific window of time. First, there's a natural increase in plasma catecholamines, which are our stress hormones like adrenaline and noradrenaline. These hormones naturally surge in the morning, which increases heart rate, blood pressure, and the contractility of the heart, all of which put more strain on the cardiovascular system. We also see a parallel increase in cortisol, another significant stress hormone, which is also naturally elevated in the morning as part of our body's wake-up cycle, further contributing to systemic stress. Concurrently, there's a natural increase in blood pressure and heart rate that happens as we transition from sleep to wakefulness, putting additional sudden demands on the heart. Furthermore, there's increased platelet aggregation. Platelets, which are small cells involved in blood clotting, become stickier and more prone to clumping together in the morning. This makes clot formation in already narrowed coronary arteries much more likely. And finally, there's a subtle but critical shift in the balance of clotting and clot-breaking factors in the blood. Specifically, there's an increased tissue plasminogen activity alongside an increased level of plasminogen activator inhibitor 1, or PAII. This means the body is naturally more geared towards forming clots and less towards breaking them down during these early morning hours, creating a perfect storm for acute cardiac events.
Wow. So our bodies are naturally more vulnerable to these acute coronary events right when we first wake up. That's really eye-opening and counterintuitive. It means that the time of day isn't just a coincidence, it's a significant physiological factor that actively contributes to risk.
It really is. It underscores how our internal body clocks influence even these critical events.
So, if we've ruled out unstable angina or a heart attack from blocked arteries, but the problem is still clearly coming from the heart, what else could that be? It sounds like the heart has other equally serious ways of causing trouble and pain.
You're absolutely right. The heart is a complex organ, and it can cause pain from issues other than just narrowed or blocked coronary arteries, which is what angina and heart attacks represent. These conditions still involve the heart itself or nearby major vessels, but are not primarily about a lack of blood flow through the coronary arteries. These require different diagnostic approaches and treatments. Some critical examples include pericarditis. This is an inflammation of the pericardium, which is the thin sac-like structure that surrounds the heart, helping it to move smoothly within the chest. When it gets inflamed, it can cause very distinct pain. Aortic dissection. This is an extremely serious and life-threatening condition where there's a tear in the inner layer of the aorta, the body's largest artery. Blood then surges between the layers of the aortic wall, causing them to separate. Acute pulmonary hypertension. This involves abnormally high blood pressure in the arteries that supply the lungs, which can put a significant strain on the right side of the heart, leading to pain. Infective endocarditis. This is a serious infection of the heart's inner lining, or valves, which can cause a range of systemic symptoms, sometimes including chest pain. And mitral valve prolapse, a relatively common condition where the heart's mitral valve doesn't close properly. While often benign, in some cases it can be associated with atypical chest discomfort.
How does pericardial pain usually feel? Does it have distinct characteristics that differentiate it from the crushing pain of angina or the sharp pain of muscle strain?
Pericardial pain indeed has quite distinct characteristics that often help us differentiate it from typical anginal pain. It's often described as a sharp pain rather than the dull, heavy, or crushing sensation of angina. A very key feature is its pleuritic component, meaning it can worsen significantly with deep breathing, coughing, or sneezing, much like pain from lung inflammation. It also frequently changes with body position. It's postural, often dramatically relieved by leaning forward, and made worse by lying flat on the back. Crucially, unlike anginal pain, it's very rare to radiate to the hand. It might radiate to the shoulder or neck, but not typically down the arm. These characteristics, when present together, form a very distinct clinical picture that helps us pinpoint pericarditis as the likely cause.
An aortic dissection sounds incredibly serious, a tear in the body's main artery. How does that pain present? I imagine it's not subtle, not something you'd easily dismiss.
You're absolutely right. It is a medical emergency of the highest order, demanding immediate recognition and intervention. The pain of an aortic dissection is typically sudden in onset, often described as coming like a bolt from the blue. It is excruciatingly severe, often described as a tearing, ripping, or knife-like sensation, and it commonly radiates to the back, sometimes migrating downwards as the dissection progresses along the aorta. It's one of the most severe pains a person can experience, and its sudden, dramatic, and uniquely descriptive nature is a critical clue. This is not a pain that gradually builds or eases with rest. It's an abrupt, catastrophic event that commands immediate attention.
This is truly fascinating and a bit frightening. So sometimes a serious heart problem doesn't even cause pain in the chest at all. It seems counterintuitive that the heart could be in such distress without that direct alarming symptom.
Precisely. This is a crucial concept, and these situations are what we call anginal equivalents. They are symptoms that indicate myocardial ischemia, a lack of oxygen to the heart muscle, but are not the typical chest pain. Recognizing these is incredibly important because they often occur in specific populations where the typical pain response is blunted or absent. Overlooking them can lead to dangerous delays in diagnosis. These anginal equivalents are particularly common in several groups we've touched on. Diabetics. Again, due to the autonomic neuropathy we discussed, which can interfere with the transmission of pain sensation. Elderly patients with autonomic dysfunction. Similar to diabetics, their nervous system might not transmit typical pain signals effectively. Patients with chronic beta blocker and other anti-anginal drugs. These medications can mask or significantly alter the perception of pain, making typical anginal symptoms less apparent. And post-KBG, coronary artery bypass graft, patients. Their denervated heart may not send typical pain signals, requiring us to look for other indicators of ischemia.
What are these equivalent symptoms? What should someone look out for if they fall into one of those groups and aren't experiencing classic chest pain?
The most common and critical anginal equivalents we look for are, first, activity-limiting dyspnea. This is shortness of breath that significantly limits physical activity, even without any accompanying chest pain. If someone gets unusually breathless, disproportionate to their activity, perhaps just walking up a flight of stairs or across a room, and that's new for them, it could be the heart signaling distress due to lack of oxygen. Second, flash pulmonary edema. This is a sudden, severe accumulation of fluid in the lungs, making it extremely hard to breathe, often feeling like drowning or suffocation. It's a sign of acute heart failure that can be triggered by a sudden ischemic event. And third, syncope on effort. This is fainting or a transient loss of consciousness that occurs specifically during physical exertion. If the heart, due to ischemia, can't pump enough blood to the brain to meet the increased demand during activity, a person might pass out.
So if you're in one of those groups, like a diabetic, an elderly individual, or someone on beta blockers, and you're suddenly experiencing severe breathlessness or dizziness, or even fainting during exertion, that's just as serious and just as indicative of a potential heart problem as crushing chest pain. It absolutely demands immediate medical evaluation.
Absolutely. These are critical signals that the heart isn't getting enough oxygen, and they demand the same urgent evaluation and intervention as classic chest pain. Dismissing them because it's not chest pain would be a profoundly dangerous oversight. This awareness is literally life-saving for these populations.
Okay. With all this complexity, the different types of pain, the atypical presentations, the myriad causes, some from the heart, some not, where does a doctor even begin when a patient comes in complaining of chest pain? It must feel like sifting through a mountain of possibilities, trying to find that one crucial needle in the haystack.
You've perfectly highlighted the core challenge, and the answer is fundamental to good medicine. The foundation is always a thorough history and a meticulous physical examination. No amount of advanced technology can ever replace truly listening to the patient's story, the intricate details of their pain, its progression over time, what makes it better or worse, any associated symptoms they've noticed, and their complete medical background, including medications, risk factors, and family history. A meticulous history capturing the story of the pain is absolutely paramount. Simultaneously, the physical exam involves carefully looking for objective clues, checking vital signs like blood pressure and heart rate, listening to heart sounds for murmurs or rubs that might indicate valvular issues or pericarditis, listening to lung sounds for fluid buildup that could signal heart failure, and observing for signs of poor perfusion, like pale skin or cool extremities, which could point to cardiogenic shock. Being meticulous, observant, and listening intently are, without a doubt, the most important first steps. They are the compass that guides every subsequent decision and diagnostic test.
And then, once that initial assessment is done, once the doctor has that comprehensive story and physical picture, what are the first diagnostic tests that usually come into play? What's the immediate next step to get more objective, quantifiable information?
The immediate diagnostic tests typically include an electrocardiogram, ECG, and a chest radiograph, CXR. These are usually done almost simultaneously, given their speed and diagnostic value. The ECG is absolutely crucial. It's a rapid, non-invasive test that records the electrical activity of the heart. It's vital for detecting electrical changes that can immediately indicate myocardial ischemia, that lack of blood flow, or an actual infarction, meaning a heart attack. It can provide immediate life-saving information, such as ST segment elevation, which is a clear and unambiguous sign of an acute and severe heart attack that needs urgent and immediate intervention, like opening the blocked artery. The CXR, or chest X-ray, is equally important to help us quickly rule out other significant causes of chest pain that are not directly cardiac. For example, it can identify pneumonia, a collapsed lung, pneumothorax, or signs of acute heart failure like fluid in the lungs. It can also help detect signs of an aortic dissection in some cases, often showing a widened mediastinum, though more advanced imaging is often needed to definitively confirm that diagnosis. Both tests provide quick, valuable information to rapidly narrow down the possibilities and prioritize the most urgent threats.
I often hear about blood tests being rushed for heart attacks. What are the key biomarkers doctors look for, and what do they actually tell us about what's happening inside the heart?
The most preferred and exquisitely sensitive biomarkers for detecting heart muscle damage today are cardiac troponin, CTN, specifically CTNT or CTNI. Troponins are unique proteins that are normally found exclusively within the heart muscle cells. When these cells are damaged due to a lack of oxygen, such as during a heart attack, troponins are released into the bloodstream. Their presence and, crucially, a rise and fall in their levels over time are a very specific and sensitive indicator of myocardial injury or necrosis. What's particularly revolutionized diagnosis in recent years are high-sensitivity CTN assays, HSCTN. These are incredibly valuable because they can detect even minute amounts of troponin, often much earlier than older tests. This enables even earlier detection of myocardial infarction, significantly shortening the time to a definitive diagnosis and, critically, to the initiation of life-saving treatments like reperfusion therapy. It's important to note the creatine kinase MB isoenzyme, CKMB, was once commonly used as a cardiac marker, but is now considered less sensitive and less specific for heart damage compared to troponins.
CKMB can be elevated in conditions not related to the heart, such as skeletal muscle injury, making it less precise. Therefore, based on the latest guidelines, CKMB is largely superseded by troponin and is no longer recommended as the primary biomarker for diagnosing myocardial infarction. This represents a significant evolution in diagnostics, reflecting our improved ability to detect heart damage more accurately and quickly.
That's a great correction and a really important update for our listeners, highlighting how rapidly medical diagnostics evolve. Now, if someone's chest pain isn't immediately life-threatening, and those initial tests are reassuring, but there's still a strong suspicion for an underlying heart issue, what about a stress test? That seems like a common next step for many people.
An exercise electrocardiographic test, often simply called a stress ECG, is indeed a very common and valuable tool. It's used in both the emergency department and outpatient settings to evaluate chest pain when the initial tests, like the resting ECG and troponins, don't immediately confirm a heart attack. But there's still a clinical suspicion of coronary artery disease. The idea is to stress the heart in a controlled environment, usually by having the patient walk on a treadmill or pedal a stationary bike to see if any underlying blockages or blood flow limitations become apparent under increased demand. However, it's absolutely critical to know precisely when it's appropriate and, perhaps more importantly, when it's not safe to do, because stressing an already compromised heart can be dangerous.
So what are the clear indications? When can you safely and appropriately perform an exercise ECG to tease out those subtle clues?
You can safely consider an exercise ECG if several key clinical conditions are met, ensuring patient safety and diagnostic accuracy. First, there must be no evidence of myocardial injury by serial troponin tests. This means the blood tests for heart damage have consistently been negative over several hours, ruling out an ongoing heart attack. Second, the ECGs at arrival and immediately before the exercise tests should show no significant abnormalities that indicate acute ischemia or infarction. We need a stable electrical baseline. Third, there should be an absence of rest ECG abnormalities that would prevent accurate interpretation of the exercise ECG. For example, certain pre-existing ECG changes, like a left bundle branch block, can make it impossible to interpret the changes during exercise accurately. Fourth, from admission to the time of the test, the patient should be asymptomatic, or experiencing lessening chest pain symptoms, or only persistent atypical symptoms. The patient should not be having ongoing, severe, or escalating chest pain. And finally, there must be no ischemic chest pain at the very time of exercise testing.
The test is meant to provoke ischemia under controlled conditions, not to be done while the patient is already actively experiencing pain.
And crucially, when is it absolutely not safe to do? What are the critical contraindications where an exercise ECG should be completely avoided?
This list is paramount for patient safety. An exercise ECG is strictly contraindicated and should not be performed if there are new or evolving electrocardiographic abnormalities on the rest tracing. Any acute changes mean the heart is already in distress, and stressing it further would be extremely dangerous. Abnormal cardiac enzyme levels are present, specifically elevated troponins, clearly indicating ongoing heart muscle damage or an acute myocardial infarction. The patient is unable to perform exercise, for example, due to severe arthritis, significant lung disease, profound weakness, or other physical limitations. If they can't exert themselves adequately, the test is uninterpretable. There are worsening or persistent ischemic chest pain symptoms from admission to the time of exercise testing. If the patient is still actively experiencing concerning chest pain, an exercise test is inappropriate and risky. And lastly, if clinical risk profiling indicates that imminent coronary angiography, a procedure to directly visualize the heart arteries with dye, is likely already needed. In high-risk situations where the suspicion is very high for severe, unstable coronary artery disease, we go straight to definitive imaging, bypassing the stress test.
So it's a very powerful tool for specific situations, but it's a nuanced one, not just a default test for everyone with chest pain. It requires extremely careful clinical judgment to ensure it's both safe and diagnostically useful.
Absolutely. It's all about selecting the right test for the right patient at the right time.
Let's imagine another compelling scenario to solidify our understanding of these critical distinctions. Picture Mark, a 55-year-old who arrives at the ER in obvious distress. He's clutching his chest, describing sudden, excruciating, tearing pain that started abruptly and is now radiating intensely to his back. He's visibly pale, clammy, and profoundly sweaty. His initial ECG is, surprisingly, normal, but the medical team, despite the normal ECG, immediately suspects something dire, something far beyond a typical heart attack. They don't waste a second. They rush him for an urgent CT scan of his chest.
Mark's presentation is a textbook example of an aortic dissection, even with a normal ECG. The character of the pain, sudden, excruciating, and described as tearing or ripping, and its classic radiation to the back, are crucial overriding clues that point away from a classic myocardial infarction and very strongly towards this catastrophic event. This meticulous history-taking, focusing on those specific unique pain characteristics, guides the medical team to immediately bypass an exercise stress test or even waiting for serial troponin results. Instead, they correctly pursue advanced imaging like a CT scan of the chest and aorta. This illustrates how crucial a detailed listen to the patient history is to guiding the right diagnostic path quickly, especially when dealing with such rapidly progressing and lethal conditions. It's a testament to the power of the clinical art, even in a high-tech era.
So the practical application here is profound. Even when standard tests like an ECG appear normal, the specific, unique characteristics of chest pain, like sudden tearing radiating to the back, can indicate other critical conditions, such as an aortic dissection, that require immediate specialized imaging. Always, always trust the full clinical picture and the patient's story.
Couldn't have said it better myself.
Okay, you've absorbed a tremendous amount of information today, and you've truly been diving deep with us. Let's see how much has really sunk in and put some of these nuanced distinctions to the test with a few rapid-fire questions. No pressure at all, just a little interactive fun to reinforce these absolutely key concepts.
That's right. These questions are designed to help you cement some of the most vital distinctions we've covered today. Take your time, think it through, and see how well you can apply what we've learned.
FENCQ. Which of the following is not considered one of the three classic criteria for typical angina? A. Substernal chest discomfort. B. Provoked by exertion or emotional stress. C. Relieved by rest or nitroglycerin. D. Sharp, lightning-like pain localized to one spot.
Think about the quality of pain we discussed.
2. MCQ. A patient describing their chest discomfort as a heavy squeezing or constricting sensation, rather than a sharp one, is most indicative of A. Non-cardiac chest pain. B. Pericarditis. C. Typical angina. D. Anxiety attack.
Remember those key descriptive words for angina.
3. MCQ. When chest pain is accompanied by profuse sweating, a sense of impending doom, and a rapid heart rate, these associated phenomena suggest A. Parasympathetic nervous system activation. B. Sympathetic nervous system activation. C. Gastroesophageal reflux disease. GERD. D. A musculoskeletal issue.
Think fight or flight versus rest and digest.
4. MCQ. Pain that is sharp, worsens with deep breathing, and is relieved by leaning forward is a classic presentation of A. Typical angina. B. Aortic dissection. C. Pericarditis. D. Unstable angina.
That postural relief is a big clue for one specific condition.
5. MCQ. Which patient population is most likely to present with atypical features of angina, potentially without classic chest pain? A. Healthy young adults who exercise regularly. B. Individuals with well-controlled asthma. C. Patients with long-standing diabetes mellitus. D. Those experiencing acute panic attacks.
Remember the groups where pain signals might be altered?
6. MCQ. Sarah's original mild ache after climbing stairs, relieved by rest, evolved into more frequent, longer-lasting pains, sometimes at rest. This change in pattern most strongly suggests A. An improvement in her heart health. B. She is simply becoming more aware of her symptoms. C. A progression from chronic stable angina to unstable angina. D. A viral infection causing muscle soreness.
What does a worsening pattern usually indicate?
7. MCQ. Which biomarker is currently the most preferred and sensitive for the early detection of heart muscle damage during a myocardial infarction? A. Creatine kinase MB isoenzyme, CKMB. B. High-sensitivity cardiac troponin, HSCTN. C. Myoglobin. D. C-reactive protein, CRP.
We mentioned the evolution away from an older marker.
8. MCQ. Mark's sudden, excruciating, tearing chest pain radiating to his back despite a normal initial ECG should immediately raise suspicion for A. An esophageal spasm. B. An acute panic attack. C. An aortic dissection. D. A common cold.
That specific tearing description points strongly to one emergency.
9. MCQ. Anginal equivalents, such as new onset activity limiting shortness of breath or fainting during physical exertion, are particularly important to recognize because they signal ischemia, especially in A, patients who describe very sharp pinpoint chest pain. B. Individuals with a history of recurrent heartburn. C. Elderly patients and those with diabetes. D. Young athletes with strong hearts.
Who might not feel typical pain but still have serious heart issues.
10. MCQ. The circadian periodicity for acute coronary syndromes, meaning a higher incidence in the morning hours, is partly attributed to which physiological change upon waking. A. A decrease in circulating stress hormones like adrenaline. B. A reduction in overall blood pressure and heart rate. C. An increase in platelet aggregation, making blood clots more likely. D. Enhanced activity of clot-breaking factors in the blood.
What happens to our clotting system in the morning?
All right, let's go through the answers and briefly recap why each one is correct.
Okay, let's see how everyone did. 1 answer, D. Sharp, lightning-like pain localized to one spot. Explanation. This type of pain is typically associated with non-cardiac causes. The 3 classic criteria for typical angina are substernal discomfort, provocation by exertion or stress, and relief by rest or nitroglycerin, which usually involves a dull, heavy, or squeezing sensation. 2. Answer C. Typical angina. Explanation. Descriptors like squeezing or constricting are classic characteristics of ischemic cardiac pain, reflecting the heart's struggle for oxygen. 3. Answer B. Sympathetic nervous system activation. Explanation. Sweating, anxiety, and palpitations are all direct manifestations of the fight or flight response, indicating that the sympathetic nervous system is highly activated due to acute stress. 4. Answer C. Pericarditis. Explanation. This specific constellation of symptoms, sharp, pleuritic, worsens with breathing, and postural, relieved by leaning forward, is highly characteristic of inflammation of the pericardium. 5. Answer C. Patients with long-standing diabetes mellitus. Explanation.
Due to autonomic neuropathy, diabetics often experience blunted or atypical pain sensations during cardiac events, making their symptoms less classic and harder to pinpoint. 6. Answer C. A progression from chronic stable angina to unstable angina. Explanation. Any increase in the frequency, duration, or intensity of chest pain, especially if it starts occurring at rest or with less effort, is a critical sign of instability, indicating worsening coronary artery disease. 7. Answer B. High-sensitivity cardiac troponin, HS-CTN. Explanation. HS-CTN assays offer superior sensitivity and allow for earlier and more accurate detection of heart muscle damage compared to older markers like CK-MB. 8. Answer C. An aortic dissection. Explanation. The sudden onset of excruciating tearing or ripping pain that radiates to the back is a classic urgent presentation of an aortic dissection, demanding immediate imaging despite a normal ECG. 9. Answer C. Elderly patients and those with diabetes. Explanation. These populations often have altered pain perception due to neuropathy or other factors and may present with non-pain symptoms, anginal equivalents, during ischemic events, making their diagnosis more challenging. 10. Answer
C. An increase in platelet aggregation, making blood clots more likely. Explanation. The morning surge in hormones and physiological changes, including increased platelet stickiness and a shift in clotting factors, contributes significantly to the higher incidence of acute coronary syndromes during these hours.
Fantastic. So what does this all mean for us, the listeners, the learners, striving to be well-informed and truly proactive about our health? What are the big takeaways?
Well, I think we've learned today that chest pain is a profoundly complex diagnostic puzzle, where every piece of information, every subtle detail truly matters. And a systematic, thoughtful approach is absolutely essential. Firstly, distinguishing between typical angina, atypical angina, and non-cardiac chest pain is the critical initial filter. This is guided by those 3 classic criteria we hammered home: substernal discomfort, provocation by exertion, and relief by rest or nitroglycerin. This fundamental framework really helps to direct the initial assessment. Secondly, the precise character, location, radiation, and any associated symptoms, whether it's the cold sweat of sympathetic excess or the nausea of parasympathetic activation, provide vital nuance clues. Remember the profound distinction between a compressing or squeezing cardiac pain and a pricking or catching non-cardiac pain. Those words are incredibly powerful diagnostic tools. Thirdly, we must always remember that special populations, such as diabetics, the elderly, or those already on heart medications, might present with atypical symptoms or even anginal equivalents, like unexplained shortness of breath or fainting. These require a much higher index of suspicion and a broader diagnostic perspective, never dismissing a symptom just because it's not classic chest pain. And finally, while powerful diagnostic tools like ECGs, chest x-rays, and high-sensitivity troponin tests are crucial and indispensable in modern medicine, they're always best interpreted in the context of a meticulous patient history and a thorough physical examination.
Even an instant angiogram isn't always the immediate answer. Careful, empathetic listening to the patient's unique story remains paramount, guiding every single decision.
And here's where it gets really interesting, the truly provocative thought for you to carry forward. This deep dive has peeled back the layers of the incredible complexity hidden within a single symptom, chest pain. It's not just about the pain itself, but the story. It tells a story that changes with each individual, with each unique medical history, and indeed with each passing moment. So the next time you, or someone you know, feels a concerning twinge or an unexpected symptom in their chest, remember, the greatest diagnostic tool we have, even with all our advanced technology, is the power of keen observation, critical thinking, and knowing which insightful questions to ask. What subtle changes might you now be better equipped to notice, both in yourself and in those around you, to potentially make a life-saving difference?
We truly hope this deep dive has empowered you with a clearer, more nuanced understanding of chest pain and its many presentations. For more incredible educational content, remember to check out London Heartbeat's Z Academy UK. Explore their impressive range of over 150 courses. Subscribe to their free updates on Facebook, Instagram, and YouTube to stay informed. And consider their higher-level YouTube membership for even deeper insights and personalized guidance. They're an outstanding resource for continuous learning.
Thank you for diving deep with us today into this vital topic. This journey into understanding chest pain has truly been a testament to the intricate workings of the human body and the profound art of medical diagnosis. Stay curious, stay informed, and we'll see you on the next deep dive.